Welcome back, everyone. Let's continue down the ECG series with lecture number 2 and talk about ECG electrophysiology, lead placement, and we're really going to delve into how the ECG machine actually detects what's going on within the heart. As a brief reminder, remember that the orientation of the heart is slightly rotated with the left ventricle forward and slightly rotated to the left, where the apex of the heart, or the point of maximal impulse, is on the left side of the chest, and the top of the heart, or the base of the heart, is located just right of the sternal border. When we talk about the ECG machine, we use terms like placing electrodes, but we really don't put a lot of thought into what that means. We talk about lead 2, or you may have terms like lead 1 or lead 3, or the AVF or AVL lead. But we really don't do a good job at explaining in the early levels what those leads actually mean. So when you place an electrode on a patient, you're actually placing an electrode that's going to measure electrical activity along an axis. So for example, if we look at the RA, or right arm electrode here, that serves as the negative pole for both lead 1 and lead 2. Lead 1 measures electrical activity between the right arm electrode and the left arm electrode, with the left arm electrode being the positive side of that lead. Lead 3 measures the axis between the left arm and the left leg, with the left arm functioning as the negative end of the electrode and the left leg functioning as the positive end of the electrode. Lead 2 measures, as mentioned earlier, between the right arm and the left leg, with the left leg being the positive electrode and the right arm being the negative. I've applied this over an anatomical heart here so you can kind of get an idea of what areas of the heart that we're really looking at. Of course, this is not anatomically perfect or correct, but it gives you an idea of what we're looking at. Lead 1 looks at predominantly the atria. Lead 3 looks at mostly the left side of the heart. Lead 2 looks at mostly the right side of the heart. When we talk about an ECG tracing, it will deflect in the direction of the mean electrical travel towards or away from an electrode based on the axis in which it's looking. And I know that's a lot of complicated words. We're going to look at that in a different slide, a little bit more detail. So the deflection of an ECG, and we're going to look at ECG number A here, the image on the left-hand side of your screen. When electrical activity is moving towards the positive electrode, okay, it's going to make a positive deflection on the ECG tracing. Alternatively, as you can see in image B here, when electricity is moving towards the mean electrical activity is moving towards the negative electrode, it makes a negative deflection on the ECG tracing. These tracings can be mirrored depending on which lead you're viewing. And this is why multiple leads are presented in an ECG and why multiple leads are important. We know from anatomy and physiology that the mean movement, the average movement of the overall electricity is from the top of the heart to the apex of the heart, or the base, towards the ventricles. So depending on which lead we're looking at, that deflection can be positive or negative depending on which electrode that electrical activity is moving towards. When we look at Einthoven's triangle, and this is the term that we use to describe the electrode placement and how electricity is moved, each of the leads are bipolar for the most part. So lead 2 is right arm negative to left leg positive, and it evaluates the inferior diagonal movement. Lead 1, right arm being negative, left arm being positive, evaluates the lateral electrical movement. And lead 3 is left arm to left leg, and it evaluates steep inferior movement of overall electricity. Now, most modern ECG machines have 4 electrodes. And so why are we only looking at leads, the left arm, the left leg, and the right arm? The fourth electrode, or the right leg electrode, is used to establish a ground to find the center for where those electrodes are and gives you leads AVR, AVL, and AVF. You have augmented vector right, that's what AVR stands for, augmented vector left, and augmented vector foot. And you can see the direction of evaluation in the image on the screen. This gives you a center view of the heart as opposed to moving from one electrode to another. With understanding this, it becomes important to discuss ECG electrode placement. As you can see in the images that we've talked about up until now, the ECG is sensitive to measuring electrical activity between its electrodes, and so it's important that we place the electrodes in the appropriate position to gain an appropriate tracing. There are two modes within most modern cardiac monitors. You have an observation mode and a diagnostic mode. An observation mode applies algorithms and filters to help get you a nice, clean image for what you're seeing on the screen, but oftentimes can filter out nuances. For observation mode, this is when you're looking at your classic 3-lead or 4-lead ECG tracing. It's acceptable to place the electrodes on the trunk of the patient during this time, if that's more convenient for looking at observation modes and tracings. However, when you're going to move into diagnostic mode, and this is when you're acquiring a 12-lead ECG, a lot of the filters are moved back or taken off of the ECG tracing so we can get subtle changes present in those ECG tracings for diagnostic criteria. While it's important to follow the manufacturer's recommendation, as a general practice, you should move the electrodes to more distal portions of their appropriate area when you're in diagnostic mode. This is a twofold problem. One, if you've already placed the electrodes, you're going to need to move them. And two, when you're in diagnostic mode, and especially when the electrodes are near the distal portions of the extremities, you're going to get more artifact. And that's just chaoticness in the baseline, and it makes it difficult to read, especially in the back of an ambulance. It may be important to stop the ambulance if you're en route somewhere or in transit somewhere and take a clear picture of the 12 lead so you can have the best quality tracing possible before moving back into observation mode. You can certainly place the electrodes on the extremities for observation mode. Just understand that you may pick up some additional artifact, and that can create some problems. Okay, let's talk about the additional leads for a 12-lead patient. You have 6 additional electrodes that you place for 12 leads. You have V1, V2, V3, V4, V5, and V6, with V1 being the 4th intercostal space at the right sternal border, V2 being the 4th intercostal space at the left sternal border. Then we would place V4, which is the 5th intercostal space mid-clavicular line. We would then place V6, which is the 5th intercostal space mid-axillary line. V3 would then land between V2 and V4. It's likely you're going to be over a rib in this case, but try and be cognizant if you can get it just above or just below the rib. And then V5 is placed between V4 and V6. Remember that it's important to move your limb leads to the diagnostic positioning whenever possible here. Let's talk about the different views that are present when you get a 12 lead. Your V leads are looking from the electrode, so from the V1 position, directly to the middle line of the heart. We talked about how the right leg establishes a ground. This is used in conjunction with other electrodes to look from the center of the heart outward toward the electrode. Each one of the V leads are a positive electrodes, so those are going to yield a positive tracing when electricity is moving towards that electrode. Wilson's terminal is the term that's used to find that ground or that midline in the middle of the heart where these V leads will be originating from. Okay, another important component to remember are things that are what we call contiguous leads. These are leads that measure associated areas within the heart, and they're tied to coronary perfusion arteries. And so when we talk about contiguous leads, for example, the inferior leads, leads 2, 3, and AVF all view a similar area of the heart in a similar axis that is perfused by a specific coronary vessel. Septal, V1 and V2, anterior, V3 and V4, and your lateral leads for high lateral are 1 and AVL, and your low lateral leads are V5 and V6. We will use these a lot in 12 lead and looking at acute coronary syndrome. So I want to provide this information to you now so you can start committing these components to memory. Okay, talking about the 15 lead ECG and right ventricular assessment. As we know, the orientation of the heart is left ventricle forward and angled in the left axis of the chest. And so if we need to get a clear view of the right ventricle, we can move the V4 electrode to the same position on the right side of the chest as the left side of the chest. We can move that electrode, I'm going to say that again, we can move the V4 electrode in the same position to the right side as it was on the left, and that now becomes V4R, or V4 right for the right ventricle. Likewise, we can move leads 4, lead 5, and lead 6 from the anterior portion of the chest wall to their respective portions in the posterior portion of the chest wall to get V7, V8, and V9, and that would be your 15 lead ECG. One of the things that's worth noting here, when you move an electrode from the anterior position to the posterior position, you have essentially flipped the axis of the heart, or of the electrode. So as electricity is moving towards the electrode, it will be a positive deflection. As it's moving away from the electrode, it will be a negative deflection. When you move V4 to the V7 position, you have essentially flipped the ECG on its end, and whereas electricity may have been moving towards the electrode before, it is now moving away from the electrode, thus flipping the view on the actual tracing itself. Key takeaways from this. Make sure you're using diagnostic placement when you're taking diagnostic tracing. Take some time now and go ahead and commit the contiguous leads and start thinking about these ECG tracings in 3D vectors. It is the movement of electricity towards or away from a specific electrode that is driving the tracing itself. It's not contraction, it's the movement of electricity. The other thing to remember, interpretation is as much art as it is science, and interpretation as an art takes a ton of practice and a ton of time to perfect. Take the time, learn the fundamentals, and practice. This will be the key to your success.